Good evening from Charlottetown, Prince Edward Island. My name is Trevor Jane, and I'm an emergency physician in Charlottetown. Dr. Kirsten Johnson, the incoming CAEP president, asked me to moderate this week's town hall as she's providing emergency services in a remote northern community. As of today, in PEI, we've had only 27 cases of COVID with no community spread. All our cases have been related to travel. This is in part due to the checkpoints at our airport, and we have been turning away vehicles of non-islanders that attempt to cross via Confederation Bridge. We normally want people to come play on our island, but not this summer. This is CAEP's sixth weekly town hall. I really enjoy being a member of CAEP, especially during this time of crisis. I've never felt closer to my CAEP peers than during the last few weeks. CAEP enables a network of incredible individuals who are contributing to the fight against COVID, sharing their experiences, their knowledge with other emergency physicians. It is a strong membership that allows CAEP to provide you with a COVID-19 town hall, a robust information center, and all of its advocacy efforts to date. Thank you for all of you that have joined or renewed this year. It's crucial now more than ever to strengthen the voice of emergency medicine by becoming a CAEP member or donating to CAEP. You can join at caep.ca/membership or contact Christina Bova directly. Her information is on our membership page. I also want to give a shout out to Prince Edward Island's own public health officer, Dr. Heather Morrison, who's part of the Canadian public health team in the fight against the virus. She also happens to be an emergency physician, and I want to thank her for the work that she's been doing for our province. Tonight, we have two fabulous speakers on two distinct topics. Dr. Kerstin de Wit, speaking on thrombosis and the COVID environment, and Dr. Bonnie Henry, who's speaking on public health response and long-term care in British Columbia during COVID. Dr. Kerstin de Wit is trained in internal and emergency medicine in the UK. She completed a thrombosis fellowship in Ottawa and now works for McMaster as an assistant professor and a staff physician in both thrombosis and emergency medicine. COVID-19 has impacted both of these specialties, and she'll talk about how COVID-19 might change her emergency medicine practice in terms of testing for pulmonary embolism, deep venous thrombosis, as well as minimizing the risk of COVID-acquired venous thrombosis. Dr. Bonnie Henry was appointed as the Provincial Health Officer for the province of British Columbia effective the 1st of February 2018. Prior to this, she was the Deputy Provincial Health Officer for 3 years starting in August of 2014 and served as Interim Provincial Executive Medical Director of the BC Centre for Disease Control. She's also the Medical Director of Community Disease Prevention and Control and Public Health Emergency Management with British Columbia Centre for Disease Control. And she was heavily involved in the SARS epidemic as the operational lead in Ontario. She's the author of Soap and Water and Common Sense, A Guide to Staying Healthy in the Microbe-Filled World. And with those two biographies, I'd like to turn it over to Dr. Kerstin de Wit. Kerstin, over to you.
Thank you so much. So thank you. It's a real pleasure to be talking to CAEP about thrombosis and COVID-19 infection. I work as a physician in both specialties, both thrombosis and emergency. I'm very happy to share with you the knowledge that I have gleaned to date about the risk of thrombosis and how it will affect our specialty. So this presentation is going to have three parts. The first part of the presentation, I'm going to talk a little bit about why COVID-19 increases the risks of venous thromboembolism. And that will actually involve looking at the cellular level, not in too much detail, but I think it's helped explain to me what the risk is and how it affects these patients, and I hope that will help you too. The second part, I'm going to look at certain decisions that we have to make in the emergency department with regard to anticoagulation, testing and treatment for venous thromboembolism with COVID-19. And then the last topic, I'm going to focus a little bit on how you might be able to distinguish between a patient who's presenting with either COVID-19 or pulmonary embolism. How do you know when you need to test for pulmonary embolism? So I'm going to start by looking at this syndrome called HLH. So hemophagocytic lymphohistiocytosis is a hematological phenomenon that's been recognized for a decade or so by now, which was previously known to be triggered by a number of things, including malignancy and infection. But in the last 10 years has really been mainly triggered by viruses, influenza A, SARS, MERS-CoV, and now COVID-19. And has also raised its head recently with a recent development in the treatment for acute lymphoblastic leukemia in the therapy CAR-T, which is an antigen modification of T cells. The Hlh syndrome came to the forefront back in 2012 when the first patient who had this CAR-T therapy for their acute lymphoma, acute leukemia, underwent the CAR-T therapy. She was a 6-year-old girl called Emily Whitehead. When she was recovering from the therapy, she developed this syndrome called HLH and developed multi-organ failure and acute respiratory distress syndrome. And I'm going to explain to you what they discovered during that when they tested her, and a little bit about the mechanism and how that relates to COVID-19. So this HLH occurs when we have a cytokine release storm or release syndrome, where there's an dysregulated immune system. So the patient's own immune system is causing their body harm. And what happens, you get an unregulated feedback of activation of the patient's own lymphocytes, which produce large amounts of cytokines, which in turn activate the macrophages with a positive feedback. And when this patient who had undergone the first CAR-T therapy was tested, they discovered that she had very high levels of interleukin-6. And as a result, they tried completely out the blue, they tried an interleukin-6 receptor therapy, which is tocilizumab, and they found essentially that saved this 6-year-old girl's life. And since then, there's been a connection between using tocilizumab, interleukin-6 receptor antagonists, and these cytokine release storms, or HLH. So essentially, HLH occurs when you have a cytopenia in conjunction with the cytokine release syndrome, along with multi-organ failure. So how does that relate to COVID-19? So this diagram really represents the lung at the alveolar level. And I just wanted to explain the exact process of how the SARS virus causes cytokine release. So the virus migrates into the alveolus, and it infects the macrophages, monocytes within the alveolus and the dendritic cells. These activated macrophages then go on to produce cytokines, and in particular interleukin-6, which then activates T cells, lymphocytes. And as the lymphocytes become activated, they also produce large amounts of cytokines, including interleukin-6. And that causes inflammation within the lung. Now, at the early stage, on this slide on the left-hand side, it's showing the early stage of SARS infections in the lungs, where you start to have some migration of lymphocytes to the lungs. But if the disease progresses to acute respiratory distress syndrome, then we see a much greater extent of cytokine release, in this thing called the cytokine storm, where you have migration of the neutrophils and lymphocytes, as well as more monocytes into the lungs, out of the bloodstream, and laying down of this hyaline membrane within the alveolus. And then we also find that there is some fibrin deposition within the interstitial areas within the lungs. And that fibrin deposition is partly responsible for the rigidity of the lungs and the lack of compliance and the difficulty ventilating patients. You might notice at the bottom of the screen, there's also just a pictorial representation of a blood vessel. And during the cytokine storm, the endothelial cells in blood vessels within the lungs become activated and affected by the cytokines. And they in themselves become damaged and produce more cytokines, vascular endothelial growth factor, IL-6, IL-8, and the vessels become leaky, which is where we develop edema and leakage of water in further cells. So that's an explanation as to how the cytokine storm causes damage to the lungs. So essentially, this is an inflammatory condition due to a dysregulation of the immune system. But it doesn't only affect the lungs, and very importantly, it also activates the clotting system. So these same cytokines also impair the natural anticoagulants within our blood system, meaning that it's easier to form a blood clot. They stop fibrinolysis of clots, and they also activate platelets. So they really gear our blood up to develop a clot. And then over and above that, in areas where you have the damage to the endothelium is leaking tissue factor. So all of these things increase the chance that we're going to have thrombosis, particularly in the lungs, because there's so much inflammation going on during COVID-19 within the lungs, particularly when we're looking at ARDS. Of course, you'll see this as well in other blood vessels, so the veins of the legs, for example. But the impression that we're getting is that the inflammation is the greatest within the lungs, and the procoagulant state is the highest within the lungs. This is a picture that was taken of a postmortem of a patient in New Orleans who died of COVID-19. The white arrows are pointing out thrombus within the pulmonary arteries. So you'll notice that there's multiple thrombi. They're in both lungs, and they're in the smaller pulmonary arteries. So they're not found in the main pulmonary artery or the right and left or the trunk, but the more peripheral, either segmental, possibly lobar arteries. And the feeling is that these are purely in situ thrombi. So we have localized what they call thromboinflammation, so inflammation of the lungs, inflammation of the endothelium, and development of clot within the lungs. And then when, if you were to look at the tissue sections, on the upper left-hand side of the slide, there's a stain which is showing in blue the fibrin deposition. So there has been fibrin deposition within the tissues of the lungs, creating the rigidity of the lungs. And the bottom left image shows an arteriole which is surrounded by T lymphocytes, CD4 T lymphocytes. So we have a huge migration of lymphocytes to the region. And then in the center, you can see the early formation of a microvascular thrombosis. So really, all of COVID-19 association with thrombosis relates to this enormous inflammation and the procoagulant effects of the inflammation. So there's a few important points to be made. The first is that it seems that the risk of venous thromboembolism increases with the severity of the COVID-19 disease. So we think patients who are ambulant and relatively little affected by COVID-19 are not particularly at increased risk of deep vein thrombosis or pulmonary embolism. We know there have been case series now published from China, France, Italy, the Netherlands, all of which have concorded that when patients on the, amongst those patients who are in intensive care, so patients who need assisted ventilation, the risk or the incidence of new deep vein thrombosis and pulmonary embolism is somewhere within 1 in 4 of those patients. So about 25% of the patients develop pulmonary embolism or deep vein thrombosis that's clinically significant. And then when you compare that to the incidence of acute deep vein thrombosis and pulmonary embolism in hospitalized ward patients, the incidence has been reported to be about 6 to 7%. So it seems that the sicker you are, or possibly the closer to death you are, the more likely you are to develop venous thromboembolism with COVID-19. It's important to notice that the thrombus in the lung is not always pulmonary embolism and may actually be more often in situ pulmonary artery thrombosis. But even with that said, a number of the cohorts that we've seen published recently show that somewhere about a third to half of all the cases present with deep vein thrombosis. And quite a number of those patients with deep vein thrombosis had thrombosis of the calf veins as opposed to the very proximal veins that we see more usually. So again, likely in situ thrombosis starting in the smaller vessels. And then the last thing to say is that both stroke and myocardial infarction have an increased incidence with COVID-19. By no means the same increased incidence that we're seeing with venous thromboembolism. But so far, it seems that about 3% of patients who are admitted and discharged or else die in hospital with COVID-19 suffer from stroke or myocardial infarction. So what should we do differently in the emergency department with regards to venous thromboembolism? Well, I think one of the important things to think about is to specifically check our patients for signs of deep vein thrombosis or superficial vein thrombosis. There's been a lot of chat on Twitter and in the medical literature and online about whether we should be anticoagulating these patients before they develop venous thromboembolism. But as yet, there's really no proof and no evidence suggests that's the right thing to do. However, I don't think anyone would think twice about fully anticoagulating a patient if they had a superficial vein thrombosis, a deep vein thrombosis, or pulmonary embolism. So one of the things that I've started to do if I have a sick patient, and actually the sicker they are, the more I do it, is to check their legs to look for signs of deep vein thrombosis or superficial vein thrombosis, especially because I know if I admit them to the ward, I'm not really sure how carefully they'll be checked by the admitting team, particularly because of the risk of infection. So when I have the PPE on, I think it is important to look at their arms and their legs to look for any signs of venous thromboembolism. And that can be tricky if it's someone you're going to be intubating, but worthwhile doing. If we want to test for pulmonary embolism, what's the most appropriate way to approach testing? Well, we know that D-dimer is greatly elevated in COVID-19 on a spectrum from normal D-dimer to D-dimer in the 10,000s. And we know that the higher the D-dimer is, the higher the probability that the patient might end up with ARDS or dying. As yet, we don't know whether that relates to the increased risk of venous thromboembolism. But if we have a patient with COVID-19, if you're concerned that you need to test for pulmonary embolism, it's quite possible that their D-dimer would be higher than it would have been if they didn't have COVID-19. And that doesn't mean to say that they definitely have PE. So I think this is a good opportunity to use some of the more recently derived clinical decision rules to adjust our D-dimer. And I think any of these options are good options. And I would personally advocate for knowing one of these ways to adjust your D-dimer and stick to using that one. It's always important to combine that with the Wells score or the years score. So just to review again, age-adjusted D-dimer is using a threshold of the age times 10. And it's safe to do that if someone scores 4 points or less on the Wells score. Clinical probability adjusted D-dimer involves using a cutoff of 1,000 if the patient scores 4 or less on the Wells score, and a D-dimer cutoff of 500 if they score 4.5 or to 6 points on the Wells score. And the years score involves the 3 years items, which is pulmonary embolism most likely, more than any other diagnosis, deep vein thrombosis signs and symptoms, and hemoptysis. And if the patient has none of those, then it's safe to use a threshold of 1,000 in the D-dimer to rule out pulmonary embolism. And if they have one or more of those items, then you can use the cutoff of 500 to the standard cutoff for ruling out pulmonary embolism. So I think now is a good opportunity to practice using those adjustments to the D-dimer. And then the flip side is the opposite. So I've not had to perform a CT scan on a COVID patient, but I know in the US that there's been lots of talk of routine CT scans. And if you have a patient with COVID, or who you think has COVID, who needs to have a chest CT, then you could argue that you probably should use contrast because the patient's going to the scanner anyway. And if they're sick, they do have a chance of having pulmonary embolism. So it would seem like a missed opportunity not to speak to radiologists and see if they would give them contrast specifically to look for pulmonary embolism. So then the next question is, should we be giving anticoagulation to any of these patients that were admitting with COVID-19? And while there are some randomized control studies just starting now comparing low dose, intermediate, or full dose anticoagulation for patients with COVID-19 with a view to either prevent progression of the COVID disease or prevent venous thromboembolism. There's really no current evidence existing to tell us what the right thing to do is. So the general approach just now from thrombosis physicians would be that the patients should be given thromboprophylaxis, and that thromboprophylaxis should be low molecular weight heparin. There's many reasons not to use something like apixaban or rivaroxaban or dabigatran, but I think the main reason not to use it would be that if the patient's going to be offered any antiviral treatment, there are some interactions, particularly with the antiretrovirals. So I think the simplest approach would be to use low molecular weight heparin and to use low molecular weight heparin that your hospital subscribes to. And this is just an example of weight-appropriate low molecular weight heparin dosing. And it might be an option to consider giving that dose of prophylactic anticoagulation even as you're referring the patient for admission. In my mind, it makes sense that the sooner they get it, the better the benefit. It might be an opportunity to use a hospital admission order set to give the low molecular weight heparin, or else make sure to communicate to the admitting team that you've given it. But generally speaking, the standard doses would be once a day up to about 130 kilos, and then or 100 kilos, depending which low molecular weight heparin you use. And then at the larger weights to divide it into a twice a day dose. And this is just an example of dosing that you could use. I would think each hospital now has a standard weight-based prophylactic regime, so I would find out what your one is and use that. But definitely worthwhile thinking, giving a dose before the patient's admitted. So I have heard some people asking the question about what should we do for the patients who we're sending home with COVID. I suppose they could fall into two categories. They could be somebody from a nursing home, for example, who is going back to nursing home potentially to die or to be palliated. But probably most of the patients will be relatively well with their COVID, and you think that they have the resources at home that they will be able to look after themselves, and that they don't need additional oxygen and other hospitalized resources. So as yet, there's no information about the incidence of venous thromboembolism in COVID patients who are being treated at home. We don't even understand the incidence of venous thromboembolism in the patients we diagnose when they come to the emergency department. So it's really far too early to say whether offering home venous thromboembolism prophylaxis is of any help at all. It would be a little complicated because the patient would have to take low molecular weight heparin, which involves them having to administer it themselves, is costly. So if they don't have insurance, it can be expensive. So probably for now, the answer is we shouldn't be doing that. We don't know whether patients who've been admitted to hospital long term will need that when they're discharged. But I know of no hospitals as yet who have a protocol to send patients home on long-term prophylactic dosing. So I would suggest for now, if we send a patient home, that we don't prescribe any anticoagulation. But obviously, it would go without saying that if they were to worsen, they would need to come back again, and we would reevaluate that situation. And then I think this is probably the biggest potential trap for us all. I know that I struggle when I have a patient now who comes in hypoxic or breathless, because in our heads, we're so focused on COVID, it can be really difficult to distinguish between COVID and other situations. I had a gentleman just very recently who I thought probably had COVID, and it turns out that he had an aspiration pneumonia and is COVID negative. And I think pulmonary embolism is another good example of where that can trip us up. And unfortunately, just because of the pandemic, patients aren't going to stop developing pulmonary embolism, and they're going to continue to be a diagnostic conundrum. So when we have a patient who comes in with breathlessness, how do we know when we need to test for pulmonary embolism? And that's a really difficult question. So all I can do is give you my advice and tell you what I am doing, and I'm very open to hearing your opinions and further questions. So, of course, what are the symptoms of PE? Well, they're breathlessness and fatigue. Those are the two most common symptoms: exertional breathlessness and exhaustion. And of course, those probably are about the most common symptoms of COVID-19. So in this case, they're not going to help us. So what else would I look for? Well, I think the first thing which could be a really big clue is asking about previous venous thromboembolism. So if this is a patient who's previously had deep vein thrombosis or pulmonary embolism, then I think that would definitely raise my suspicions if I thought they had symptoms that were compatible with PE. And the patients who catch you out with without the history of venous thromboembolism are generally people who are so young that they haven't lived enough years to have their first episode of venous thromboembolism. And in that case, I want to ask particularly about family history. So those would be people in their late teens, 20s, 30s. If they had a strong family history of venous thrombosis, brothers, sisters, parents, then I would also think about pulmonary embolism. And then there's the other clues, patients who've undergone surgery in the last 6 weeks, or patients who had a prolonged hospital admission are definitely at risk of deep vein thrombosis and pulmonary embolism. And then the slightly softer things, which would be no clear history of fever, although I'm sure it's possible to have COVID without a clear history of fever. But with pulmonary embolism, fever is not a prominent symptom. And of course, lack of cough or lack of symptoms of an upper respiratory tract infection are important to look for. And I think if you're worried about pulmonary embolism, then the advice would be to test. And how would we test? Well, of course, we would use exactly what I was spoken about already. I would say use the D-dimer in the way that you normally adjust it, depending on their clinical probability. And if they need a CT scan, then CT scan is probably the right thing to do. So in summary, I would start off by saying that COVID-19 essentially is a disease of the immune system, or at least people who develop ARDS have a disease of the immune system, which is associated with cytokine release and thromboinflammation, and deep vein thrombosis, pulmonary embolism, arterial thrombosis, and in situ pulmonary artery clotting. We should be thinking about giving early thromboprophylaxis to everyone who's coming into hospital. We should always be looking for clinical signs of clots, and the easiest place to see clinical signs of clots are in the legs. And at the back of our minds, we're always going to have to remember not everyone who's breathless has COVID, and we just somewhere have to remember to double check that there are no additional risk factors for pulmonary embolism. And if anyone has any questions, then I'm happy to open up to questions.
Hi, Kerstin. Excellent presentation, and we do have a few questions there from the member for people that are watching that are coming in. One of the questions is, could you speak to the relative incidence of VTE in patients in the ICU that are non-COVID compared to the quoted incidence of ICU patients with COVID? I think you mentioned, I was trying to track there, about 25% for COVID patients.
So with COVID, it's anywhere between 25% to 40%. So there have not been large cohorts published, but we have got probably 4 cohorts in publication at the moment, all of somewhere between 100 and 200 patients. And they report between 25% and 40% with either deep vein thrombosis or pulmonary embolism. I know that one study also included clotting of the renal replacement therapy line in those figures. When you look at the incidence of venous thromboembolism in all ICU patients pre-COVID, the incidence is pretty low. It's about 3 to 4%. If you look at the incidence of patients admitted with pneumonia, it might be a little bit higher, but it's not a lot higher. So COVID-19 is very different in that it's much more associated with thrombosis inflammation.
Okay. All right. One of the other questions we received, Kerstin, was, there's some debate in the literature about unfractionated heparin instead of low molecular weight heparin. Is why the choice? Can you clarify the choice one versus the other? You mentioned in your presentation there.
So it wouldn't make a difference for the prophylactic dose. You could give standard unfractionated heparin at 5,000 units 2 or 3 times a day. That's exactly equivalent to the prophylactic dose of low molecular weight heparin. The major difference would be if you were wanting to fully anticoagulate a patient, particularly a patient you were worried about bleeding, then IV heparin is a little bit more versatile because the moment you turn it off, it's gone from the body. You don't need to reverse it. And the other patient group we would use IV heparin for are patients who have really end-stage renal failure. We can give prophylactic dose low molecular weight heparin in patients with renal failure, but we can't give treatment dose. And really a conservative cutoff would be a creatinine clearance of 30 or less. So for those patients, and I'm thinking of like COVID patients with multi-organ failure, then they're more likely to be treated with IV heparin.
Okay. One of the questions that we also were receiving, you mentioned about the D-dimer cutoffs, and you acknowledge that some centers may not have the scarcity of CTs and other people are CT and lot. Is there any recommendation with POCUS or other labs? And I acknowledge, we're acknowledging it's a new disease, and but I was just wondering if you could comment on that.
Mm-hmm. So I think the problem with POCUS is decontaminating your machine. But if you have a nice way to do that, then I see no reason why you might not want to use it. I think it has limited utility if it's somebody who's come in and you're pretty sure they have COVID and you're wondering, could there be an element of PE? Just because they have right heart strain probably won't be very specific for PE in that case. I know the COVID cases have right heart strain. By all means, use it as long as you can clean your machine.
Yeah. Okay. And I'm sure we discussed before, like you mentioned in the Twitterverse, that COVID toes is what's going around. So I'm sure there's merge docs. We're starting to see people come in with discolored toes, and they're concerned about COVID. Have you heard colleagues or seen that's a clue to COVID? Can you comment on the?
I too have heard about it on the internet. I haven't seen it actually, but it makes perfect sense. The patients have a higher risk of stroke and arterial thromboembolism. So one of the common places to have a thromboembolus is to the legs, in the arterial supply to the legs. So it's not a surprise that we might see cyanotic extremities.
Okay. Another question, very interesting topic, we can tell by the questions that we're getting. You mentioned about the cytokine release syndrome or cytokine storm, and you mentioned the dosing. Is there thoughts that we should just, if we feel that that's occurring, that we should just go ahead and anticoagulate these patients without evidence of thromboembolic? Is there evidence to show that this is a treatment for that, or?
There's been just one paper with only a very few patients where they followed the D-dimer after starting anticoagulation. And they showed that the D-dimer level comes down once you start anticoagulation. The problem is that we don't really understand the relationship between the very high D-dimer and developing blood clots. So that was really using a surrogate outcome. So as yet, we don't know that anticoagulation is a treatment either for COVID or is good. Therapeutic dose anticoagulation we don't know that's the right thing to do to prevent venous thromboembolism. I'm hoping we'll have some studies soon.
Okay. And it's a new disease, and we're finding out different things all the time, and we're finding that it can present a bunch of different ways. I was wondering if you could clarify. You mentioned about sending somebody home on prophylaxis. Will we still recommend somebody with limited mobility, living in a care facility or a nursing home, if we suspect COVID? Maybe they're just on the threshold. Should we err on the side of caution and give it, acknowledging risk, behavior,
frailty? The problem is, it's a great question. I think the problem is we don't know which side is erring on the side of caution.
Right.
We think that giving low molecular weight heparin doesn't have any side effects. We don't know for sure if it's prophylactic dose. I guess it could be an option, but that nothing has been published on that. You would have to have really good communication with the family physician provider. You'd need to know, someone was going to review how long it would be given for. So it could be tricky.
Yeah, for sure. No, for sure. Listen, we really appreciate your time, and I know there's going to be lots of questions that are going to be generated, and we can compile those. And if you'd be so kind, we might send you a few that we could follow up on. But in the interest of time, we're going to move for our next speaker, and I just want to say fantastic job, and thank you so much for volunteering your time and expertise. You're welcome. So I did have a chance to catch up with Dr. Bonnie Henry yesterday afternoon, and I'll give it over to Jeff there to let's see what she had to say, and it was a Q&A format. So Jeff, over to you. Thank you so much, Dr. Henry, for joining CAEP. We really appreciate your time and the efforts that you've been doing on behalf of people from British Columbia and Canadians.
Well, thank you for having me. And hello to all my CAEP friends, many of whom I haven't seen for quite a while. So.
Yes, thank you so much. I'm going to just jump into a few questions that our membership had. One of the things that we've noticed is that many long-term care homes have experienced significant devastation related to the COVID infection. And staff are always cross-deployed, working in multiple sites. And British Columbia has done a really good job in successfully curtailing the spread within the nursing homes. You've centralized staff and restricted workers to one home. Can you share some maybe key lessons learned or some experience in operationalizations of these guidelines for long-term care homes, or any advice for other jurisdictions?
Yeah, well, one of the challenging things was here in BC. We've all been experiencing our own pandemic, and one of the things that happened early here was an outbreak in quite a large long-term care facility, in Lynn Valley Care Center here in Vancouver, and so that really made us hyper aware of how devastating this virus can be when it gets into those settings. As well, we're very close, as you know, to Washington State, and there were a number of very large care home outbreaks in Washington State. So we did early on take some very aggressive actions. As most people are aware, public health spends a lot of time with long-term care homes during influenza season, and we have a respiratory protocol that we have implemented in British Columbia that we have every year, and I know every province in Canada has a very similar thing. And we work very closely with our homes around detection of respiratory illness, the testing in the care home, and then outbreak control measures. So when we had the first outbreak, and unfortunately a number of residents and staff, by the time it was noticed, a number of residents and staff were ill, and we've now had 20 deaths in that in residents in that care home, and 50 some people who were affected in the in residents overall. So we put in place very strict infection control measures. So everybody wore masks, we restricted visitors, we do all of the things that isolating people who were sick. It became very apparent though that residents themselves can have very mild symptoms and also die very quickly. So that's something that we learned very early on, and we made the decision quite early on because after the first outbreak, we had still others very close, very soon after. And as you say, part of that was because we have so many staff that work in multiple facilities, and it was quite complex, particularly in the Lower Mainland in British Columbia, where we have 2 health authorities, but quite a few care homes, long-term care facilities, assisted living facilities, and particularly the care aides work in multiple facilities. And this had been contracted out a number of years ago, so people had small hours here and there. So what we have done, and we took it across the province, was initially the orders were just in Vancouver Coastal for the outbreak facilities. People could only work at that outbreak facility. Okay. But then we recognized that this was going to be an issue across the province. So we took outbreak measures in all of our healthcare, all of our long-term care facilities very early on. So we restricted visitors, we put in resident screening, healthcare worker screening, and we initiated the process to have what we called the single site order. So that was something, it's a provincial health officer order that requires across the province that staff work at only a single site. It, as you can imagine, was very challenging. We had 6 different unions that were involved. We had many different collective agreements. We had private, public, private pay, different. So we've made it across the board for the duration of the pandemic. Excuse me. But I expect that we will be looking at how we can move that forward beyond the pandemic. But for now, we've created a new agreement for everybody. We've particularly in the care aides, there's really wide variation in the pay scale that we were given. So we've now moved everybody up to the higher level, plus by to increase everybody to be as much as we can towards full-time hours. So okay. It's a complex process, and it's still not fully implemented across the province, but I think it has been an important way to prevent those transmissions.
Thank you for that, Dr. Henry. Did you find that a bit of a challenge? You mentioned about the collective agreements and the different unions, but was there a significant number of staff that worked multiple sites? Was that a bit of a challenge, or was it a few percentage of staff?
It was a huge challenge, to be honest, and we engage with, we have what's called the Health Employers Association of BC, so it's all of our health authorities. So we engage with them, and they worked with a private company to develop an IT system, and the first order that I gave was to require all care facilities to provide the list of their employees and how many hours they worked by health authority, and to ask every employee their preference of what facility they want to work at, given so we had a whole list of parameters that needed to put in place so that we could level the playing field, as it were. And then we put it all into a large IT system. And we're talking about close to 30,000 employees.
Wow.
And the vast majority of them did all work at one place. But there was around 4,000 or 5,000 who worked at more than one place, and some people worked at 5 or 6 different places. So it was a massive effort. We got it all into an IT system. That was step number 1, and that took some weeks, as you can imagine. And then by health authority, we had to look at who worked in which health authority, who worked long-term care and acute care. There's people who worked in were paramedics who did shifts in care homes on the weekends, things like that. So it was very complex. We now have it all sorted out, and each of the health authorities now working on those particularly affected people, and it's been more challenging for the larger health authorities, Vancouver Coastal and Fraser Health, because there's lots of people that go back and forth between those 2 health areas.
Okay. Well, another question that our CAEP membership came up a number of times there, and I think the public's realizing now, kind of prior to COVID, how much strain and chronic under-resourcing that long-term care facilities had. Many homes are struggling with staff. Some poor access to PPE and some of the infrastructure that maybe doesn't lend itself to isolation of residents with COVID. As this pandemic evolves, what advice would you have for long-term care providers, maybe to bolster their ability to deliver appropriate care, but also limit the transition of COVID?
Yeah, so right now, some of the key things that I believe are really important is we know that healthy people can often have very mild illness, and most of our healthcare workers are younger and healthier. So we know that we've had introductions of the virus into the long-term care from healthcare workers, either being mildly ill. We all know, a presentism problem in our healthcare system, and we think, oh, it's just the sniffles, it's just a minor thing. I can't leave people short, so I need to go in. So one of the key things that has been important is everybody wearing masks. Masks not necessarily to protect me as a healthcare worker, but masks to keep my droplets from infecting others. We do wear masks at all times in all of our long-term care facilities, and that's a really important thing because it has prevented. And when we still have people who, particularly healthcare workers, who have tested positive. Had a number of them in the last couple of weeks, even, but they've not been transmitting to residents because they've been wearing masks, and that's made a huge difference. Okay. We've also, of course, decreased visitors and all of those other important things, which is very challenging, as you say, in care homes. It's, the families provide a lot of care to their family members, and not allowing visitors reduces the chances of somebody else bringing the virus in, but it also affects the health and welfare of the residents. So we need to balance that, and we're looking now for going to our next phase of how can we allow at least one family member to come back in a safe way on a regular basis to support their family members. And I believe that PPE will be part of wearing masks and be part of that as well.
Yeah. Do you? I know you were significantly involved and were a leader during the SARS response in Ontario, and were heavily involved with that. You mentioned this phenomenon of presentism as opposed to absenteeism from work. Did you notice a change post SARS with that in healthcare providers, that they took more ownership of their health prior to a shift or a work day? And do you think that's going to, from COVID, once this pandemic settles, do you think that will become part of our normal health culture as healthcare workers?
I hate to say it, but you know what? After SARS, we lost a lot of that, and it was still very much about risk to me as a healthcare worker, as opposed to the risk that I have with my, to my patients or to my coworkers. And we're seeing that quite a bit as well, that we may be taking precautions. We're seeing patients or residents, but then we go to the lunchroom together and we share meals and we close together and we spread the virus to each other in lunchroom or in our break room, or traveling back and forth to work together. So those are the things that in the time of a pandemic, we need to be really careful about. And this has, this pandemic, the impacts have been so widespread. I am hopeful that this concept of I need to protect others from me when I'm sick is going to be more long-lasting, widespread, not just in healthcare, but important in healthcare, but also in society. And we're seeing these large outbreaks in workplaces where people are working sick and they don't have ability to stay home because they're going to lose their job. So we need to really rethink some of our, at least for the next year or more, I'm hoping, longer term. And in healthcare, for us as physicians, as nurses, as people who are working in the healthcare system, we need to be acutely aware of the risk that we present, not to our patients, not just the risk that we have ourselves. And wearing masks on a regular basis, particularly if we have any concern at all, I think is an incredibly important thing that we're going to have to vote going forward. Not respirators.
Right.
We don't need a respirator to keep our droplets in. And,
right.
A good surgical mask is what we need.
Right. Yes. Excellent. Excellent. There was a lot of, Dr. Henry, there was a lot of articles and in the Twitterverse about end-of-life goals and talking with family members and getting those advanced directives. Have you noticed that from your team or from your feeling in British Columbia an uptake in those discussions, or maybe you can comment on what you feel are they important discussions to have? We always talked about it pre-pandemic, but maybe you can comment on the importance of advanced directives and end-of-life care goals. And should we, as emerge docs in the emergency department, be bringing it up more with our encounters, regardless of age, perhaps?
Yeah, it is something. We've done something that I feel really passionate about, and it came out of the SARS outbreak, was making sure we had an ethical framework for decision making around the important things that we have. We have one for, our duty to care. We have one around personal protective equipment and how we will use that in our healthcare system. We have one around access to scarce resources like ventilator care. And why I bring that up, because that is part of it. When we started having these outbreaks in long-term care, the question was, do we move people in an acute care facility? And
right.
We had discussions with the family about, do they want, and in long-term, these are people's homes, and it can be devastating to their health, as you well know, in the emerge, when people get transferred into an acute care facility away from things that are common and comforting to them. For the most part, we have not had elderly people who want to go into hospital and they get infected with COVID. And that speaks to the care that they've been receiving in their home. It also, I must say, speaks to the fact that in many elderly people, this virus can be lethal very quickly.
Mm-hmm.
And so that's something we're watching. But yes, we have had those conversations, and I've talked publicly about having those conversations with your family members. And us as healthcare workers, though most of us are at lower risk of having severe illness, we know that we can be exposed, that we can have more severe illness, then we need to be prepared as well. So it is one of those important conversations to have, and now is an important time to have it.
Okay, very good. What speaking of those conversations and people more comfortable in a long-term care environment, and maybe not wanting to go to the emerge because they've given direction and that sort of thing. Can you comment on, the hospitals have tried to empty in some jurisdictions to kind of create capacity. Then they have the capacity, but they haven't really filled up in some jurisdictions with acute care patients, but they can't transfer patients to long-term care. And I imagine it's a bit of a balancing act between not able to transfer to long-term care, but keeping your hospitals, reasonably empty for acute care. Is there, could you comment on that challenge, probably within your venue, within your jurisdiction, or What do you think is a
It absolutely is a challenge because particularly as we're realizing more long-term care facilities might be affected. So the alternate level of care patients that were in our hospitals, and we certainly did decant, as you know, the term decant into long-term care homes. And it set up a process that, as we know, is a very challenging one for transferring from acute care into long-term care. And the rationale behind it was this is temporary, that we needed to ramp up our surge capacity. You know, obviously most of the space that we have and we continue to have in BC, thankfully, is from the decreasing and stopping of scheduled surgery. But as we start looking at how do we ramp up those scheduled surgeries and which ones would we do so that we still maintain that surge capacity in our hospital system, but particularly in our critical care system, to be able to care for people if we start to see a spike again. You know, it's a very tenuous balancing act. And, you know, I think for emerge physicians, you guys have, at least in our jurisdiction, the volumes in emergency departments have been half of what we saw prior to this. But we're now starting to ramp up again. I think there was a lot of people that stayed home because they were concerned about catching virus if they went to the hospital. And so we've been messaging to people, if you are sick, call 911. If you need it, care is there and it's safe for you. So we're starting to see people going back. And what I'm concerned about is that we're going to see people who were not effectively managing their chronic condition ending up in hospital or in ICU because they've tipped over their heart failure or they've not been managing their diabetes appropriately and now are in a more dire strait than they would have been had they been. So, I mean, all of these challenging things, we are not looking at moving people back into acute care, these alternate level of care, but we are looking at how do we find the best permanent placement in the community for you. And that's going to be part of our challenges over the coming months as well. Recognizing we are not out of the woods in terms of this pandemic, and we are likely to see surges again, at least in the fall when respiratory season starts again. So how do we find that balance of being able to open up effectively without stopping and creating more problems, more health problems, more other problems, but at least more health problems in the community right now.
Yeah, and thinking ahead and looking forward, you know, in the fall, in the second surge, and you know, some of the questions that we got was, is this an opportunity to maybe do a full reset or a full control alt delete of the healthcare system and redesign it that we can maintain surge capacity, that we can focus on long-term care? Like if you were given the ability and the resources to influence Canada, could we look at this as an opportunity? And if you had a wish list, is there some things that you would want to see change that we could have an opportunity to do that?
Absolutely. If I was the queen of the world, those are the things that I think we do have these opportunities. You know, I think there's a lot of understanding of how we created such a challenging healthcare system across the country that was always operating above capacity, that we had the challenges of people not having supports in the community going into the emerge and when they need to necessarily have emergency care in a hospital. So how we build our community out, and you know, some of the things that have been monumental changes that have helped us through this phase, and I hope will continue, are the virtual care. You know, we have moved ahead in virtual care in a way that that would not have been possible had we not had this crisis. And that is helping. It's helping keeping people out of the emergency department. It's helping. So how do we continue that? And how do we, I think we now have an opportunity that the policy people and the political people and the people with the money recognize that redundancy in our healthcare system is not, because that's what we have had for a long time, and particularly, you know, in our hospital system, but also in public health. where we have been whittled away and whittled away and whittled away because, prevention is not politically, the tyranny of the imperative takes over, and we lose some of our prevention resources. So I am hopeful that this is going to, I know at least in British Columbia for the coming year, at least we're looking at our urgent, we have the urgent primary care centers in our communities, and how can we use them to be respiratory assessment centers, but also to keep people from need to go to the emergency department. How can we have that balance of virtual care and emergency care to keep people without overwhelming our system again, and focusing on some of the important things we've learned around surge capacity in critical care, and what we're working on our high acuity units and being able to scale them up and down with, part of it is physical, having the space, but the other, as we all know, is having the personnel who are able to work in those environments. So I'm hopeful that at least for the next year, we're going to be learning and being able to use that as a model for our healthcare system. And then, as we get through this, how do we keep going for the future?
Yeah, so definitely lessons learned and things that we can look to the future to improve. I personally felt as a CAEP member a sense of team, a sense of belonging. I felt like in the trenches with my colleagues, but I'm also concerned about mental health, both with our healthcare workers and our patients. And I'm sure you may have seen the article on the emergency physician that committed suicide who was heavily involved in the COVID response. And is there things that we should be doing with both our colleagues or our patients to prevent or even manage mental health during this crisis?
Yeah, and absolutely. And this is something we've been focusing on, having mental health supports in our communities. We know that when times of crises, domestic violence goes up, gender-based violence goes up, violence against children goes up. We know that, and when people are anxious and stressed, we get reactions that can lead to mental health concerns, issues. So we all need to be aware of that, and I think it's incumbent on us as leaders to be able to support people, to recognize when people are in those times of crises, and to have the ability to support them, to be able to say, you need to take some time off, but also to make sure that there is a place that they can go to the connection that they need. And we do have mental health supports that are working and active across the country, both for healthcare workers, but also for everybody else. This is something that really came out of SARS. And I joke about my SARS PTSD, but it is very real. And I certainly felt that anxiety in January when things were happening, and it was, SARS all over again. And the impact that it has on us, the anxiety that we feel, the anxiety we were all feeling when we were decanting our hospitals and stopping surgeries and waiting and not knowing how bad it was going to get, and seeing what was happening around the world. Those are the things that stay with us, and we need to take care of ourselves. And we talk about that a lot, but we know that our sleep is going to be disrupted. We know that we're going to be working long hours. So how do we find a time to, for me, it's things like meditating, like making sure I do go for my run when I can, but not, and also be gentle with ourselves. I talk a lot about kindness, and kindness is the only thing that is going to get us through this. And recognizing when somebody's going off and angry, that it's a manifestation of their anxiety, and that we need to support people and support each other, because that's what's going to keep us healthy, both mentally and physically through this.
Yeah, that's really good advice, Dr. Henry, and we all should take that to heart, both as healthcare workers and as patients. A holistic approach to our health during this pandemic. Great great things for us to follow. Thinking about mental health and our healthcare workers, and speaking as an emerge doc, we're always kind of worried or concerned about coming in at that night shift, and the emergency rooms, at least in my jurisdiction, are starting to creep up, which is good because we want to see those patients. We want them safe. We, as you said, to preempt any chronic diseases that could be getting worse. But one of the things some of the membership has mentioned is, when the pandemic slows down, is there a way that we should mitigate like the surge of patients? So you've mentioned before, you articulated very well, the delayed surgeries, the chronic illnesses that are delayed. Then all of a sudden, I'm going to use the term all clear. I realize it's not a one day thing. And then we get this
a little bit clear.
Clear, yeah, stepwise clearance. And then we get this kind of influx of patients. And I wonder if there's ways that we should be thinking ahead to mitigate that, just for everybody's sake.
We are certainly planning in Columbia, and I know other provinces are as well, a stepwise approach, looking at it, particularly for the next 8, 10, 12 months, to get us through till next spring, to get us through to all a vaccine.
Right.
Because we still have to learn how to live with this virus and keep it at a low level in our community. And avoid those rapidly aggressive outbreaks. So that's going to be our focus for the next while. So how do we do that with ensuring that people without COVID get there they need? And again, I think goes back to planning for the scheduled surgeries. So making sure you're not going to schedule the ones that are inevitably going to end up in your ICUs for a long period of time. Okay. Looking at how we can balance those. And part of that will be making sure that they get optimal medical care to prevent you from needing that emergency surgery in a period of time. So how can we use virtual care? How can we connect with people who we know have chronic illnesses in our community? And then monitoring very carefully in emerge. And this is a part that your members are going to be thinking about. How do we ensure that we're in a day-to-day basis monitoring who's coming into the emerge department for what, so that we can back things up into the community, and we can recognize when we start to see people with respiratory illnesses coming in again, and making sure that we can treat and do that safely.
It's interesting you mentioned about the vaccine, because we've already had patients ask. I think they get it that the vaccine takes a while to obviously, it's a new disease. We got a new test. You identified it all in the last 4 months of vaccines being worked on. How do you vision like the rollout for Canada? And maybe I'm asking such a question way in ahead, but patients ask me, when the vaccine comes, how do I get it? Is vulnerable groups first? Would be healthcare workers? How do you think that would happen?
Yeah, so that is part of our planning for the pandemic influenza. So we do have a Canadian pandemic influenza plan, and one annex is about mass vaccination and how we would roll it out. So that will be the framework that we'll be using. And yes, it will absolutely be, I believe it will be likely that we will not be able to do everybody all at once, but we'll be looking at how that affects different communities. But healthcare workers absolutely will be part of it, as will, as we know, seniors and elders are most likely to have severe illness. And then we'll be looking at people with chronic disease, and we'll also be looking at more communities, First Nations or Indigenous community, because we know if it gets into a smaller community, that the probability of it getting is less if we have right things in place, but the impact can be severe. So there is a framework that we'll be using. I'm really hopeful we'll have a vaccine all the amount of work that's going on around the world for the vaccine. I keep my fingers crossed, but that is going to be a really important thing for us. Having said that, the other thing that I think is important is remembering that influenza season is coming as well. And it'll be important for us to protect ourselves from influenza, so that we're not having both of those things as we've had for the last little while. In BC anyway, a couple of weeks ago, 100 people that we tested for COVID, 1 or 2 of them would test positive for COVID, 20 of them would test positive for influenza. So,
Okay.
the importance of protecting ourselves from the other respiratory virus as much as we can is going to be heightened when we come to respiratory season again in the fall.
Okay. Okay. Good. That's good to know. Good to know. Being respectful of your time. One of our final questions is, we've seen trending COVID warrior on Twitter. I don't know if you've seen shout outs, and they're calling healthcare warrior providers COVID warriors. So what can we do as emergency physicians to bring our the clinical firepower to the fight? What would you like us to do as a membership that we can support you and your colleagues fight against this virus?
Yeah, no, thanks for that. You know what? I think we are all in this together, and having that solidarity and supporting our public health world in the community, but also you guys are the gatekeeper and the front door to a hospital system. So you're being aware, you're being able to treat people safely for COVID, building that confidence in the rest of the healthcare providers that we can do this and that we do it safely, and we can care for everybody else who needs to safely as well. But all of those things are so important, and I do look to physicians and people who work in an emergency department are the people who are used to seeing chaos, right? You're used to seeing anything walk through your door. So you're being able to effectively care for people who have respiratory illness, know which ones have COVID, know how to care for them safely. That builds confidence in everybody in our system that we can get through this, and we'll do it okay, and we'll do it together.
Thank you so much, Dr. Bonnie Henry from British Columbia. On behalf of CAEP, we really appreciate your time. We know you're oppressed, and it's valuable, and we just appreciate you being part of the incredible team that Canada has to continue to contain, mitigate, and respond to this pandemic. Thank you so much.
Thank you all too.
And that was Dr. Bonnie Henry from British Columbia. I just wanted to take the opportunity to thank both speakers this evening, both fantastic speakers. Dr. de Wit, thank you very much for your time and generate a lot of interesting questions. And thanks to Dr. Bonnie Henry, who happens to be an Islander, Prince Edward Island. And thank you as well for your time. I want to thank all the people that watched this evening, all the people that are going to choose to watch at a later date. And please be kind to one another, look after each other, and please be safe. And we'll see you at next week's town hall. See you next week.